Jessica Halsey with Addiction Policy Forum. I'm very excited to have two experts and members of our scientific advisory board here at APF with us today for today's webinar, Food, Sex, and Pornography, Addressing Process Addictions in Treatment and Recovery. A little bit, I could do really quick introductions. Our researchers have quite impressive resumes and lists of publications and books that they've published. But just to give you a quick background on their expertise and their subject matter expertise, I want to introduce Dr. Nicole Avena, who is the Associate Professor of Neuroscience at Mount Sinai School of Medicine in New York City. And she's also a visiting professor of health and psychology at Princeton University. She's done really groundbreaking work in developing models to characterize food addiction and the dangers of excess sugar intake. She's written several very popular books. Her latest book, Sugarless, covers the latest on science on sugar addiction and how to overcome it. We also have with us today Dr. Marc Potenza, who's a board-certified psychiatrist with a subspecialty and certification in addiction psychiatry. He is a professor of psychiatry, child study, and neuroscience at the Yale University School of Medicine, where he is the director of the Division of Addictions Research at Yale, the Center of Excellence in Gambling Research, the Yale Research Program in Impulsivity and Impulse Control Disorders. He's also on the editorial board of 15 journals, including the editor-in-chief of the Current Addiction Reports. He serves on several national and international awards. And as I mentioned, they are both members of our scientific advisory board for Addiction Policy Forum, which helps guide the work of APF. So I'm going to pull our screen down and first hand it over to Dr. Avena, and then we'll pass the mic over to Dr. Potenza.
All right, well, great. Thank you so much for inviting me. I'm really grateful to be a part of the Addiction Policy Forum and all the amazing work that they've been doing over these past several years that I've been a part of the group. And I'm really excited today to be a part of this webinar because I think that we are hearing more and more about how the landscape of addictions is changing and how do process addictions fold into that. And so I'm excited to talk to you today about some of the work that we've been doing in my lab and a lot of others have been working on as well that relates to food. So I want to start off by just giving a brief outline of what I hope to cover in the brief time that we have together today. But I want to touch on the evolving landscape of addiction. And I think that this is something that is very important because we're really moving into an area of somewhat uncharted territory in the sense that we are now finding that more and more behavioral addictions are emerging. And Dr. Potenza will obviously be talking about pornography and sexual addiction, gambling, but again, we're seeing that it's moving beyond just drugs and alcohol as substances that are of concern. We're now finding that there's more interest in understanding about how some of these behavioral addictions or process addictions can emerge. I want to talk a little bit about the shared brain mechanisms that are seen when it comes to the development of addiction to drugs of abuse and how that relates to food as well. One of the things that's also evolving in our landscape is our food landscape. We now find that the majority of the foods that we're eating are highly processed foods. It's very, very different than the foods our great-grandparents ate 100 years ago. I want to talk a little bit about sugar. Sugar is something that we've been focused on primarily because it seems to be the primary ingredient in ultra-processed food that is driving the addiction-like responses that people can have to it. So I want to spend some time talking about the research that we and some others have been doing in that space, and then hopefully leave some time at the very end to talk about some of the questions that might come up and potential next steps in terms of how will we combat this issue moving forward. So I mentioned process addictions or behavioral addictions are something that we are seeing more and more about, and we're starting to learn more about these. And these are things such as gambling addiction, internet addiction, sexual addiction, even shopping addiction. And we're finding that the DSM is beginning to recognize many of these process addictions in ways that allows us to understand them and warrant further investigation and exploration. Now, I will say that food addiction is not officially recognized by the DSM as of yet. However, I'm fairly optimistic that in some capacity, it certainly will be, hopefully very soon, because this allows for avenues through which we can get additional research funding to better understand it, and also so that individuals who are struggling with it can get the necessary resources to get help that they need to combat it. Now, these are some newer data that I have been working on, but I put this out here because what this graph is showing you is a culmination of many, many different studies that have been published looking at addiction to a variety of different substances, ranging in things that are, illegal, such as heroin, to things that are legal but regulated, such as tobacco, to things that are legal and very widely used, such as caffeine. And what we see here is when we put all of these studies together and look at the severity in terms of whether or not the studies show people are meeting severe, moderate, or mild addiction, based off of the DSM criteria for addiction, you can see that ultra processed food comes in pretty close to the top. We see that there is significantly more studies that are suggesting that people are endorsing the severe symptoms of addiction or on that side of the spectrum when we're looking at things like ultra processed food. So again, this is important because it really does sort of lay out what I like to view as the addiction landscape of all these different substances that people are using to some degree, and in some cases can become addicted to or dependent on. And what does that addiction look like in terms of the severity of it? So we can see that certainly processed food is a player and potentially an important one based off of the amount of severity in terms of the addiction that it can produce. Now, one question that we have to grapple with is, well, what does food really have to do with addiction? When we're talking about addiction to things like drugs and alcohol, traditionally, food has been something that people don't really put into the same conversation. But I think it's important that we keep in mind that we know from the research, the classic studies that are out there, that crossover addiction between food and drugs has been around for quite some time. These are just some old papers that I pulled that go back into the 1970s, where researchers were reporting about how there was a crossover addiction that would emerge between the preference for sweet foods and also those who have a history of drug use. In this case, it was opiates. So again, the idea that there is this relationship between excess use of food or consumption of certain types of foods and addiction to things like drugs or alcohol has certainly been in existence for quite some time. It's only been pretty recently, though, in terms of the research years, that we've been able to really uncover what that addiction to food might look like. Also, if we take a look at the AA Big Book, going back into the 1930s, it was noted that having sweets can be a great way to help resist the urges for alcohol. So again, this relationship between food and drugs in terms of addiction has been around for quite some time. If not empirically, it certainly has been in the communities that are struggling. Now, here is a map that shows across the United States drug overdose mortality based on the different states in the United States. And so we can see that certainly some states have much higher mortality rates, like West Virginia, than other areas of the country. Now, what I want you to keep in mind is when we take a look at this map and then look at the states, instead of looking at drug overdose mortality, we're now looking at obesity prevalence. And we can see that it is very much many of the same exact states that are struggling with this dual problem, if you will, of drug overdose mortality and incidence of obesity. And so what we're seeing is that there seems to be this relationship in terms of these two conditions happening often in the same places at greater rates than others. So the question that started all this for me, just to give a little backstory as to how I got even interested in this to begin with, was I was a graduate student at Princeton. I was doing my PhD, and it was literally day one of graduate school. And I started to talk with my advisor about what I might work on for a project. And going back in time, this was back in the year 2001, we're seeing a lot more stories about obesity in the media, and there was a bit of a concern mounting over the public health issue of obesity. But back then, the onus of someone being obese was still on the person who was obese. It was thought that if you're obese, it's because you don't have willpower. And it was in many ways thought to be a moral failing, that you just didn't have self-control. And I found that to be a little curious because, at that time, while obesity rates were going up, we were also seeing changes in our food supply. There were a lot more processed foods coming out, and the food environment was changing. And so we started to think about this idea if, well, maybe the food is getting people addicted to it, and that's what's causing obesity. And so, again, this idea had been around for some time in the sense that people often would talk about how if they went on a diet, they would crave certain types of foods and that they felt compelled to eat certain foods. But there hadn't been any empirical studies designed to actually test whether or not a food could meet the criteria for being an addictive substance. So basically, that's what I set out to do. So before I get into the research, I just want to take a step back and talk about how our food landscape has changed. So we evolved from hunters and gatherers. We used to have to forage for food, maybe wander around in the forest for days looking for an animal to kill or for a fruit or some berry bush that we could sustain ourselves off of. You used to have to work really hard, and that food foraging has changed. Now, this is more like what it looks like when we're trying to acquire our food. You can go to the grocery store, load up your cart, put it in your refrigerator at home. The foods have preservatives, so we don't have to worry about them spoiling. And it is certainly easier to procure our food and to store it thanks to the industrialization of our food supply. It's also even easier. You don't even have to go to the grocery store. You can literally just pull out your device and click a couple buttons and someone will bring it to you. So certainly we don't have to work quite as hard for our food anymore. And that's a good thing, obviously. But we have to ask the question, does that come at a cost? We now have an excess of food available in many cases. It's interesting, a few months back, the World Health Organization released some statistics that for the very first time in the history of keeping track of these things, more people in the world are dying from obesity related conditions than are dying from starvation. And so we've done a great job of reducing the number of people starving, but we've replaced that with another problem of people dying due to excess consumption in many cases. We've also seen changes in our portion sizes over time. Back in the 1950s, if you had a hamburger at a restaurant, it would be maybe around 4 ounces. And for some reason, if you look back to 2006, it had jumped up to be about 12 ounces in size, and it's gone up even greater since then. And this isn't just for hamburgers, this is pretty much for all of the foods across the board. The portion sizes that are presented when we were to get any of these items has gone up. And we have certainly no need for excess calories. If anything, we probably need fewer calories than we did 20 years ago because more people are in sedentary jobs and aren't burning off those calories that they're consuming. So the point I want to make here is that obesity is an endpoint, and there are multiple contributing factors. We talked about food accessibility and portion sizes, but there's other things like sedentary lifestyle, genetics, certain genetic disorders like Prader-Willi syndrome have obesity as a side effect. There are stress and endocrine factors. There's also social norms regarding food that all can contribute to excess calorie intake that can contribute to obesity. But what I want to talk about is this sort of new piece, this idea that maybe there's something about the rewarding or the hedonic aspects of the food that make people consume it in excess. And could that be an addiction? And how can we better understand that? So before I get into the addiction piece, I just want to pause for a minute and ask the question of what is a food? Now, for the I would say, the majority of my career up until just a few years ago, I was very heavily focused on the addiction piece, and I still am, and we'll talk about that in a minute. But lately, the question I've been grappling with isn't so much about, how do we define addiction? What is an addiction? It's more about what is a food? So let me give you some examples. This is a nutrition facts label. You can see we have all this information here that tells us about the ingredients. At the bottom, it says that it's whole baby carrots, frozen and unprepared. And so when you look at that list of ingredients, it's pretty obvious that this is a bag of baby carrots and this is a food. Now, let me give you an example of another food. And keep in mind, this term food is an important word, and it is an umbrella term that has many, many things under it. So when we look at this nutrition facts label for this food, we can see that, again, same information about calories, fat content, sodium. When we get to the bottom and look at the ingredients, it's a bit different. We see that there are lots of things in this particular food, and it's not quite so easy what this is. So I can tell you right off the bat, it contains multiple forms of sugar. It has sugar listed. It also has dextrose. It also has corn syrup solids, all of which are forms of sugars. It also has carnauba wax, which is something that the food companies can put into food so that it'll melt at a certain temperature when it hits your mouth, and it'll have this savory effect. It also has things like yellow 6 and red 40 and yellow 5 lake, which are basically colorants that are used just to make the food look pretty and look a certain color. They have no nutritional value, nor does the carnauba wax. But again, this is a food, just like carrots. But I think you'll agree with me that they're very different. This is a highly processed food. There's no such thing as a mini crisps Pop-Tart tree that you can buy at the nursery and plant in your yard. You can't get the seeds to grow these things at home. These are a man-made, highly engineered food product that is available for us to eat. And it's designed to look a certain way, smell a certain way, just have that feel when you put it in your mouth. It's going to make you want to buy more and more of it. And unfortunately, what we're seeing is our food supply is dominated with these highly processed foods. And the question I ask you is, should these be in the same category as foods like whole baby carrots? So the big difference is processing, right? The Pop-Tarts are a highly processed food. So you might say, well, what's the big deal about processing? We process food all the time. You peel a banana before you eat it. You sear a steak before you eat it. Processing in and of itself is a part of the way in which we interact with food. We need to often process food to make it safe to eat. But I think we could be going too far. And I'll give you some examples. You can take a food and process it and turn it into something that is very, very different than what you started with. So this is a coca leaf. In parts of the world where these leaves grow, people will chew on them. Can help with altitude sickness. And in the years of studying addictions, I've never met anyone who's met anybody who's been addicted to coca leaves. But you can take a coca leaf, extract the primary ingredients, add a bunch of chemicals to it, and turn it into something that is highly processed and very addictive, like cocaine or crack cocaine. Same with grapes. Grapes are a delicious fruit, but you can have a grape-based product that is highly processed, add a bunch of stuff to it, and turn into something that can be addictive for some people. So perhaps the same could be said of wheat. You could have a wheat-based product and turn it into something that is a highly processed version of that. And also the same with water and also sugar cane. Much like the coca leaves, where sugar canes still grow these days, people chew on them. I've never heard of anyone having a problem with chewing on too many sugar canes, but if you process them and add a bunch of chemicals to them, you can easily turn it into something that can be very difficult for many people to regulate their intake of. So why worry about sugar? We started off with sugar because it seemed that there was evidence to suggest that sugar was particularly problematic. There had been a lot of anecdotal reports of people claiming that they had a sweet tooth and that sugars seemed to be something that people found hard to resist when it came to making healthy food choices. Also, when we take a look at the data, we've seen that our sugar consumption has gone up dramatically over time. If you look back into the 1800s, people rarely consumed sugar. And if you look back into now, I mean, we can see that the amount of sugar that people have consuming has gone up significantly. Now, if we take a look at those same data and lay upon that the obesity prevalence, you can see that when we first started reporting about obesity in the early part of the 1900s, you can see that as sugar started to go up in terms of our consumption, that's when we started to see the rise in obesity rates happening. Now, this is in a bit of hindsight, but I also think it was wise to focus on sugar because just a few years back, a paper came out of Harvard from Frank Yu's lab showing that long-term consumption of sugar-sweetened beverages and also artificially sweetened beverages had increased risk for mortality due to cardiovascular disease. Now, this was a big deal to me because it was really the first paper to show that sugar-sweetened beverages was basically causing people to die prematurely. It was shortening people's lifespan by causing cardiovascular disease. Whereas the rhetoric up till that point had largely been, at least in the public eye, that fat was the thing that was starting to cause heart disease, and fat was the thing that people should be avoiding. Also, we, for the longest time, had no idea how much sugar was too much sugar. We didn't have guidelines from the government until 2015 in terms of how much sugar people should be consuming or what would be a recommended amount that would be appropriate. We had recommendations for protein, vitamin A, everything else basically, but not for sugar. But in 2015, we did get them. Now, it's not a pretty story, unfortunately, because the recommendations were that people should consume between 6 to 9 teaspoons of added sugar each day. But it turns out that the average American consumes about 17 teaspoons of added sugar each day. So right off the bat, people are consuming probably twice as much sugar as what would be recommended. So why is it hard? This is a question that I initially really drove my interest in this topic because as rational humans, if we know that eating too much of these foods is bad for us, why wouldn't we just stop? And we have all this public health information warning people about the dangers of obesity and metabolic conditions that can arise, yet people still find it extremely difficult to cut back on their sugar. Well, there's a few reasons that I think are key as to why that is. First is that it's dominating our food supply. When we take a look at the amount of products that contain sugars in them, we can see that it's the majority of the foods in the food store. So when you go to the grocery store, you're basically foraging for foods that don't have added sugar. In this paper, and this is a couple years old, these numbers have gone up. This was back in 2013. Barry Popkins' group showed 68% of the products by proportion of calories contained caloric sweeteners. Now, that number, again, has gone up, and certainly we've seen a boom in the number of products that contain low-calorie or non-nutritive sweeteners as well as they've become more and more popular. Another reason why people don't control their intake or have a hard time is because they don't realize how much sugar they're consuming. Just as one example, somebody might indulge in one of these beverages now and then, especially on a hot day like we're having in the Northeast right now. But one of these beverages is 64 grams of sugar. That's 128% of what is recommended for the entire day. So if you have just one of these, you're already dipping into tomorrow's allotment of the amount of sugar you should be consuming. Now, we all know that frappuccinos aren't exactly a health food, but let's look at something that is, like yogurt. Lots of people are encouraged to consume yogurt because it's got probiotics, it's got protein, but many of these products that are available also contain a lot of added sugar. This one in particular has 24 grams, almost 50% of the daily recommended amount. And unfortunately, due to the marketing, someone might think they're actually making a good choice by buying this because it has fruit in it. But it turns out that there's actually not real fruit in it. It's some sort of fruit compote that's basically the fruit boiled down to be just the sugar, and then some more sugar is added on top. Lastly, we're addicted to it. And I think this is where the research, to me, is very convincing in terms of what our next step should be when we think about how we're going to view these foods in our food supply. So one of the things that happens when drugs are abused is that they activate brain systems that reinforce natural behaviors. We have a system to reinforce behavior. We don't have a cocaine system or an alcohol system or a cookie system. We have a reward system. And all of those things can activate that same brain system. Drugs can become addictive because they can overactivate or overstimulate, or in some cases, people use the term hijack that primitive system that was put in place to reinforce natural behaviors like sexual behavior and eating. So the overlaps are there in terms of the brain pathway to suggest that some of these designer foods are potentially affecting the brain in ways like drugs of abuse can. So I want to just walk through some of our research. This is just a few selected studies. We've published a lot in this. We have over 100 peer-reviewed papers on the topic of food addiction and how sugar plays a role. And so if anyone's interested in getting access to those, I'm happy to share afterwards, or you can reach out to me. But what we've essentially been doing over the years is to take the DSM criteria for substance use disorder, which is how we're defining addiction, and just basically ask the question, can we see that with sugar, or can we see that with highly processed food? So when we first started doing this work, it was, like I said, back in 2000, we didn't have a model to go off of, so we had to develop one. So we started off using a rat model, and basically we just gave rats sugar water to drink, and they also had food, they also had plain water, so they were never forced to drink the sugar water. And we looked at their behaviors and changes in their brain. And what we found was that these animals that were binging on the sugar, they had 12 hours a day to get access to it, they would start to show signs of binging and also tolerance. They would drink more and more and more sugar over the course of the 21 days of the experiment, which is indicative of tolerance. And compared to other groups that had maybe occasional access to sugar, or you were getting sugar available 24/7, but just weren't binging on it, the rats that had binge access or intermittent access were showing these binges in terms of their intake. We also conducted an important control group in which rats just had 12 hours a day or limited access to their healthy rat food, because one might say, well, maybe if you have limited access to broccoli, you'd binge on that. Well, it's not about the limited access, because when the animals have limited access to healthy food, they don't binge on it. It's only when they have sugar that they seem to develop this binge-like pattern of intake. Now, we were interested in the brain. And so one of the things that we wanted to do was see what happens to dopamine levels. Dopamine is a neurochemical that is released in response to drugs of abuse. All drugs of abuse are known to increase extracellular dopamine levels. That's one of the mechanisms through which it can produce its effects. Now, you see this happening with nicotine, morphine, alcohol, you name it. It doesn't typically happen with food, only if the food is novel. So if it's the very first time you've ever consumed something, then you're going to be on high alert and your brain's going to release dopamine in response to it. So we had this question of, well, what's going to happen with sugar? Will it release dopamine every time the rats consume it, like a drug would, or will it release dopamine just the first time they have it? So the first day of the experiment, all the rats in the different groups we ran released dopamine when they drank sugar, which would be expected because that's what happens when something's novel. But if you look out onto day 2 or even day 21 of the study, when the rats are getting sugar, they're releasing dopamine. This is like what you would expect to see when animals receive a drug of abuse. This is not like the effect you would see when animals are eating a food. And if you look along the bottom, again, we had animals that had limited access to just their healthy food to see if the time schedule had anything to do with it, and it did not. These animals with limited access to healthy food did not show an increase in dopamine levels. So there's something about binging on sugar that's causing these animals to release dopamine in the brain in a way that's more like a drug and less like what you'd expect to see with a food. We've also noted signs of withdrawal. There's been lots of studies. In this particular study that I'm showing here, we looked at signs of anxiety when we take the sugar away, or we can even precipitate the withdrawal by giving an opioid antagonist, naloxone, which suggests that the opioid system is being altered as a result of the excess sugar consumption. We've also, in other studies, shown that there's evidence of depression, there's alterations in brain neurochemicals that, again, support this idea that the animals are in a negative state that is similar to what happens during withdrawal from different types of drugs of abuse. Now, my colleague, Ashley Gerhardt, and her graduate student now, Professor Nicole Avena, have done a lot of great work looking at the human side of this. And we've collaborated quite a bit over the years on this. And most recently, they have developed a measurement in which processed food withdrawal can be ascertained in humans. And I think this is really important because what the research tells us is that the peak experience of withdrawal seems to happen between days 2 and 5 of giving up the sugar or of reducing the processed food. So again, this is important because this allows us to have this overlap between what's happening in the animal work, and also we're able to see a way in which we can measure this in humans as well. Now, I'm gonna go a little quickly because I don't want to take more time than was allotted for me, but I also want to point out that we have looked at other foods besides sugar, and we've begun to do more of this. When in this particular study, we looked at something called the cafeteria diet, which is a diet that has a variety of different foods, chocolate chips, cookies, cheese, marshmallows, all different delicious things. And lo and behold, rats will get overweight on this. It's called cafeteria diet-induced obesity. What we found in this study was that these animals are sensitive to amphetamine. If we give them an injection of amphetamine, they release more dopamine than animals who were fed a healthy diet. So this suggests that that cafeteria diet is altering their brain in a way that's making them sensitive to dopaminergic stimulants. If you look at the bottom, what you'll see is that in animals that are fed the cafeteria diet and become overweight, when we give them food to eat, they don't show an increase in dopamine levels. It's only when the animals are given the junk food back, the cafeteria diet, that they start to show an increase in dopamine. So if we can extrapolate this to humans for a minute and think about it, when people have a history of eating all these processed foods and then are given something healthy to eat, it's not rewarding. It's not going to affect dopamine levels. It's only when they get the junk food back that they feel pleasure from the substance that they're consuming. So that's something important, I think, to keep in mind, thinking ahead of how we can help people who are maybe coming off this background of a history of overeating food. Now, as I mentioned, there's been quite a few research groups that have been focused on the part of this that is the human aspect. And I'm not going to go through these studies, but I will just highlight the fact that essentially what we're seeing in humans is very similar to what we were seeing in rats early on, in that activity in the brain is enhanced in response to being primed by many of these pictures or even experiences with these highly processed foods. And that seems to be related to food addiction severity. So the higher one scores on a food addiction scale, the greater the neural activity in these reward-related brain regions. So Ashley Gerhardt's group and I, we published this paper together a few years ago. The question is now, well, which foods are addictive? We've talked about ingredients, but I think moving forward, we need to understand which foods are addictive so we can know how we could maybe make them unaddictive, right? Can we change them? And what we found from this particular study was that the largest predictor of whether or not a food was identified as being addictive, and by the way, it's probably no shock that pizza, chocolate, and chips were the top 3 most addictive foods, was the level of processing. So the more highly processed the food, the more likely it is to be addictive. And I think that that is something we need to keep in mind when we take a look at our food landscape and look at the number of foods out there that are extremely processed and have many of these different ingredients that in many cases don't add to the value of the food in terms of the nutrients. So they're there for aesthetics. So to summarize, the criteria for addiction have been met when the substance of abuse is food. And this has been shown in animal studies. It's also been shown in humans. And so the last thing I'll leave you with is the question that I'll often get as pushback, which is this really like a drug addiction? Like, what about the loss of control? And I think we need to keep in mind that a large part of addictions are social constructs. Society determines what is and isn't allowed. Society has regulations that say this is allowed and this is not. And a lot of that plays into whether or not someone has to experience loss of control as a result of their addiction. So we need to keep in mind that when we look at addiction from the purely biochemical standpoint, the most common addict in our society is actually a smoker, fully functioning, little noticeable intoxication. The withdrawal syndrome is not life-threatening, but because of the health complications linked to tobacco use, it is still the #1 preventable cause of death in the United States. And I think if we're going to consider addiction to food, we need to think about it in the way that we've over the years looked at tobacco. So last thing I'll say, in the end, food is not a drug, but we need to keep in mind that the addiction components of it are there, and we need to understand it, how it relates to other addictions. We also need to keep in mind the pervasiveness of this is very different than drugs of abuse. Impacts on health and the impacts on longevity are extremely important for us to keep in mind. So it's very easy to dismiss this idea of food as being addictive because of the normalcy around all of these foods. And if you go to other parts of the world, I was in Europe speaking in Italy just a couple weeks ago, and you get a reminder about how you can live without all this processed food. People have been doing it for hundreds of years and they're just fine. But when you come home, it's a very different landscape here. It was actually quite alarming when I got through customs in New York that the very first thing I saw when I got to the United States was a kiosk of junk food. So again, it is something that is extremely pervasive, and I think we lose sight of that because it's become so normalized. And I will end there, and I'm going to turn it over to Dr. Potenza. Thank you for listening.
Thank you. I will share my slides. And I will be shifting gears and talking about sexual behaviors, particularly problematic pornography use and compulsive sexual behaviors. I have a listing of disclosures with respect to pharmaceutical, gambling, gaming, legal, nonprofit entities. And for the talk today, I thought I would review how sex has been viewed from healthy and unhealthy standpoints over time. Um, in particular, considering how the DSM, the Diagnostic and Statistical Manual, and the International Classification of Diseases have considered sexual behaviors, and how we might be in a different era now with respect to digital technologies and how that might relate to sexual behaviors. So the World Health Organization has defined sexual health, that it requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. And there can be many adverse aspects of sexual health that may include sexually transmitted infections, among other concerns. How people have defined healthy sexual behaviors has changed over time. And for example, we can think back to about 50 or so years ago when gay and lesbian relationships were considered within a pathological framework. However, these have changed over time, and there's been a focus on the harmful consequences or psychological distress that is related to the sexual behaviors for the sexual behaviors to be considered within a disorder or disease framework. And I think importantly, there have been questions raised about whether impulsive, compulsive, or addictive sex may be considered from a psychiatric perspective. So this brings us back to some of the points that Dr. Avena discussed in her talk. What is addiction? And while she focused on what is food, I'll focus more on what is addiction. And the word from which addiction is derived is a Latin word meaning bound to or enslaved by. And in its original formulation was not linked to substances. However, by the 1980s, it was felt that the term addiction could be defined by compulsive drug use. However, by the 1990s, people like Howard Schaefer proposed some core elements: continued behavior despite adverse consequences, diminished or lost control or compulsive engagement, and a craving or an appetitive urge state that preceded the engagement in the behavior. And if we think of these as the core elements of addiction, then perhaps the term can be applied to a wider range of behaviors. Constance Holden, in two papers in the journal Science in 2001 and 2010, kind of bookended a decade in which there could be considered a swinging of the pendulum towards the concept of behavioral addictions gaining traction. So in the first article, she asked whether behavioral addictions existed, whether we could use new technologies like brain imaging to look at similarities between substance use disorders and, say, gambling disorder. And then in 2010, she had the article Behavioral Addictions debut and proposed DSM-5, which heralded the reclassification of gambling disorder together with substance use disorders in the DSM-5. So as mentioned, the DSM-5 is it's the 5th edition of the Diagnostic and Statistical Manual, and it's one of the main nomenclature systems for psychiatric conditions. The other is what the World Health Organization puts out, the International Classification of Diseases, and its 11th revision came out more recently. So in anticipation of DSM-5, there were a number of controversial topics, as evidenced here in this Time magazine imagery. This article, entitled What Counts as Crazy, had a caption of the new abnormal ? And we heard about food and binge eating. I'll focus more on the other two topics that are listed there, sex addiction, and that in some ways intersects with internet addiction. So what happened in DSM-5 with respect to behavioral addictions? Gambling disorder was the new name for the condition, which was previously known as pathological gambling, trying to reduce the stigma and remove barriers for people entering treatment, for example. It was renamed, but also importantly reclassified as an addictive disorder together with substance-related disorders. There are research criteria introduced for internet gaming disorder, which was also considered by the same committee. And then a separate committee considered hypersexual disorder, but while it was recommended, it was not included in the DSM. So what is some of that history? So going back over 20 years, Patrick Carnes proposed core criteria for sexual addiction. And the criteria for hypersexual disorder in some ways overlapped with those criteria for sexual addiction. And one can see that some of what was proposed as for hypersexual disorder had some of these main elements of addiction, including repeated unsuccessful attempts to control the behavior and impairment in functioning related to engagement in the sexual behaviors. So there was a field trial for hypersexual disorder that was conducted prior to DSM-5, and the Sex and Gender Identity Disorders Work Group, which considered hypersexual disorder, recommended it for inclusion, but the APA decided against including the condition. And it was felt at the time by a number of individuals that this decision may hinder both research and clinical efforts in this domain. And there were a number of individuals who were working with the ICD-11 work groups, particularly the Impulse Control Disorders work group, began to consider compulsive sexual behavior disorder. During that time, Shane Krause, who's now at the University of Nevada, Las Vegas, had an interest in trying to understand what are the existing literature and whether compulsive sexual behavior should be considered as an addiction or not. And there were data at the time that suggested from biological and treatment perspectives that this warranted consideration. So also over the past 10 to 20 years, there have been changes in the ways in which people consume pornography. Pornography use has been a prevalent behavior for a longer period of time, but it's now more frequently conducted online. And some recent data suggest that 92 to 98% of men and 50 to 91% of women, depending on the study, consume pornography. And pornography use has been associated with both perceived positive and negative health effects. But from a clinical perspective, problems related to pornography viewing appear particularly prevalent in men, particularly in men seeking treatment for hypersexual disorder. So Some of the similarities with respect to substance use disorders are reflected in some of the pharmacological treatments that have been explored. It should be noted that there are no medications with FDA indications for problematic pornography use or compulsive sexual behavior disorder. This is a case report of an individual with problematic pornography use who initiated cognitive behavioral therapy targeting the pornography use, and that helped reduce the frequency of pornography use, but craving increased during that period of decreased consumption. So naltrexone was added with a subsequent decrease in craving. So this finding resonates with findings from the alcohol field and other research areas. However, this is a case report, and some placebo-controlled trials have not found efficacy for naltrexone over placebo. However, as is the case with gambling disorder, there are mixed data with respect to the efficacy of opioid receptor antagonists, in this case, nalmefene, where in this randomized controlled trial, the active drug was superior to placebo. So another medication class, serotonin reuptake inhibitors, which are widely used for the treatment of anxiety and depression, was investigated in this case series, which found that individuals with problematic pornography use showed decreases in pornography consumption and decreases in anxiety with respect to paroxetine treatment. However, there was also the emergence of new problematic sexual behaviors with respect to paying for sex as well as extramarital relationships. So it's important to get a full history from individuals. However, the mainstay of treatment for people with compulsive sexual behavior is behavioral treatments, and these include acceptance and commitment therapy, which is shown to be helpful for individuals. And we have an article that was published now about 5 years ago in Psychiatric Times that reviews the existing status of treatment. So as there were with, say, gaming disorder, there were debates about whether compulsive sexual behavior disorder should be included as a diagnostic entity in the ICD-11. And some of the data that existed at the time suggested that compulsive sexual behavior and problematic pornography use showed similarities with addictive disorders, and it might be considered as a disorder due to addictive behaviors. Some of those data came from Valerie Boone and colleagues while she was at Cambridge. Specifically, brain imaging studies of men with and without compulsive sexual behaviors showed that the men with showed greater activation of the anterior cingulate, ventral striatum, and amygdala to sexually explicit cues, and that the degree of integration of these brain activations to these cues was more robust in the men with versus without compulsive sexual behaviors, and linked to sexual desire in a more significant way. There have also been reports both from Valerie's lab as well as from Robert Asture's lab of attentional biases towards sexual cues in individuals with compulsive sexual behaviors, as well as in a general college population in a manner that was linked to the severity of problematic pornography use in this heterogeneous sample. But these findings suggest that there may be ways in which to redirect or redirect attention, or to have clinical interventions that are based on these findings, as has been done with substance use disorders. In a separate study out of Poland, Mateusz Gola and colleagues found that in a modified version of a monetary incentive delay task that had either monetary cues or erotic cues, that the men with problematic pornography use showed this activation difference in the ventral striatum, a brain region implicated in reward processing, mainly with respect to the cues being linked to greater bold signal changes in the men with problematic pornography use as compared to those without. It was not seen when people received either the monetary or the sexual reward in terms of imagery. And the degree of ventral striatal activation during that specific cue phase was linked to a variety of out-of-the-magnet measures with respect to sexual addiction severity, amount of time viewing pornography, and weekly number of masturbations. So while there has been a lot of focus on biological factors, there's also been significant focus on environmental factors, and these two domains are intertwined. One area of significant interest is with respect to sexual abuse and its relationship to sexual behaviors. And there have been links between both childhood sexual abuse and adolescent and adult sexual abuse to hypersexuality in both men and women, with data suggesting a stronger link in men as compared to women. Now, as I mentioned, how people have used digital technologies has changed significantly, and of the many forms of behaviors in which people can engage on the internet, pornography is one prevalent behavior. So how prevalent is pornography use? This slide now with data that are close to a decade old suggested that at the time, Pornhub, one of the main pornography websites, received over 87 billion views in a year, and at the time was considered, the parent company, MindGeek, was one of the top 3 bandwidth consuming companies in the world, with the other 2 being Google and Netflix. So prevalent behavior. And it has been proposed that the availability, accessibility, affordability, and the perceived anonymity of the internet may have promoted pornography consumption, including among youth. And there have been reports by young adult men that their viewing of pornography during their adolescence, that they have linked this to erectile dysfunction in early adulthood or emerging adulthood. This notion made the cover of Time magazine close to a decade ago, where there were reports asking the question whether internet pornography might be causing sexual dysfunction. And it has also led to movements like NoFap and Reboot Nation, which are online forums for people who are trying to quit pornography use. So what about compulsive sexual behavior disorder? It's been estimated that about 3 to 5% of the general population have lifetime prevalence of CSBD, and about 1 to 3% being a past year prevalence estimates, with estimates higher in men as compared with women. Problematic pornography use as a potential component of compulsive sexual behaviors, because men with CSBD, men often report more frequently than women having problems with pornography use, women more so with in-person extramarital or infidelity types of relationships. So problematic pornography use in multiple studies has been linked to multiple negative outcomes, including impairments in one or more important domains of functioning, as well as with psychopathology, poor self-esteem, and poor attachment, and is particularly prevalent among particularly men seeking treatment for hypersexual behaviors. We were interested in understanding among people who view pornography, how many were either interested in seeking treatment or currently seeking treatment for their use of pornography. And in a sample of about 1,500 men, we found that about 1 in 7 reported an interest in seeking treatment, and those who reported interests in seeking treatment were more likely to meet criteria for hypersexuality, as well as be viewing more pornography. So in this setting, the World Health Assembly met in May 2019 to adopt the 11th revision of the International Classification of Diseases. And how behavioral addictions were considered changed significantly. So gambling and gaming disorders were included as official clinical diagnoses that were classified as disorders due to addictive behaviors. Gambling disorder had been included. Gaming disorder was a new condition. Importantly, also hazardous gambling and hazardous gaming criteria were included. And this is akin to the hazardous or harmful alcohol use criteria that the World Health Organization has defined that are, I think, very important for public health interventions. And then compulsive sexual behavior disorder was included as an official new diagnosis, but it was included as an impulse control disorder and not as a disorder due to addictive behaviors. So what were the criteria for compulsive sexual behavior disorder? The core elements are highlighted in orange, including failure to control intense repetitive sexual impulses or urges, that it becomes a central focus to the extent of neglecting health and personal care or other interests. There are unsuccessful attempts to control the behavior and continued engagement despite adverse consequences. So a lot of what we see as the core elements of addictions. And there's also this compulsive element that is defined that I would argue may also occur in substance use disorders, that the person continues to engage in the behavior even when the individual derives little or no satisfaction from it. And then there also needs to be significant impairment in one or more other areas of functioning. And then there is this moral disapproval statement that distress that is entirely related to moral judgments and disapproval about sexual impulses, urges, or behaviors is not sufficient to meet the diagnosis. Doesn't mean that people cannot have feelings of moral disapproval about their behaviors, but it's not sufficient in and of itself. And when we have looked about moral disapproval, we see this applying to a broader range of addictive behaviors, including gambling, gaming, and other concerns. And one can also envision this, that people may not feel that behaviors in which individuals engage in to support, for example, substance use disorders may not align with their moral judgments and views. So how pornography use is considered has also continued to be debated as the CSBD criteria have been more filled out. There's been specification of pornography use within the CSBD domain. But some individuals have also proposed that this may be considered as an other specified disorder due to addictive behaviors, because for especially this term is important for other behaviors like shopping and buying and use of social media, for which there is not a specific disorder presently in the ICD-11. So As mentioned, a number of the core features of addiction seem to be in the definition of compulsive sexual behavior disorder, but it was classified as an impulse control disorder, which is the place where gambling disorder used to be prior to DSM-5 and ICD-11. And it raises the question about, does it really matter whether this is an impulse control disorder or a disorder due to a behavioral addiction? In some jurisdiction, it has more weight than others. So, for example, in France, addiction clinics are mandated to provide care for people with substance or behavioral addiction. So, if a disorder is considered as an addiction, it may determine in part where they can seek care. However, having a formal diagnosis within the formal nomenclature system of the ICD-11, I think is very helpful and should assist with respect to research, training, and intervention purposes. So the other omission by having compulsive sexual behavior disorder within the impulse control disorder group, arguably, is with respect to the lack of a hazardous engagement entity definition. And as mentioned, this entity of hazardous or harmful use of alcohol has been very helpful in terms of identifying individuals who may be at elevated risk or engaging in a behavior in an unhealthy fashion, but not yet rising to the level of a disorder. Now, what about youth and pornography use? So this is a Huffington Post article from about 5 years ago that describes the author's daughter stumbling onto pornography when doing a search for My Little Pony. So some youth can find pornography inadvertently, and others may seek it out. And data from an internet service provider found that the proportion of 7 to 12-year-old children viewing pornography has statistically significantly increased from one 5-year period as compared to the prior 5-year period. And underage pornography viewing may, as was mentioned previously, alter sexual arousal templates, but also influence expectations that youth may have when going into relationships, and may also lead to abusive situations, particularly as the content of pornography has changed over time. And what was previously considered gonzo or extreme pornography has become more mainstream over time. And also of note is that in one study out of Korea, using the internet mostly for pornography compared to other reasons had the highest odds ratio for what might make adolescents addicted to using the internet. So how might early engagement in pornography use alter developmental trajectories, I think, is an important question. So some studies out of Poland found that among university students, 80% viewed pornography, and there was a median age of onset of pornography viewing of 14 years. Earlier age of onset was associated with the need for longer stimulation and more sexual stimuli to reach orgasm, decreased sexual satisfaction, poorer quality of romantic relationships, neglect of responsibilities, and increased odds of problematic pornography use, with the highest odds being seen with the youngest age group, those who had initiated prior to age 12 years. Among adolescents in general, pornography use has been linked to poor body image, poor youth development, poor family functioning, depressive features, and it's also been linked to the non-consensual forwarding of sex in youth, particularly amongst youth with instrumental attitudes towards sex. So instrumental attitudes are seeing individuals more as an object rather than being in a romantically connected sense. And this forwarding of sexual imagery is really important and can be very impactful. One documentary that demonstrates this is the documentary Audrey and Daisy, which was made as part of a legal settlement where several teenage girls were sexually assaulted and had the imagery shared. And since the time of the documentary, one girl had committed suicide by the time the documentary had been made, and the other girl has since committed suicide. So not an easy watch, but an important topic to cover. So going from pornography use to partnered sex, individuals who view pornography may expect for a partner to engage in what they are seeing in pornography. Dating victimization has been linked to adolescent pornography viewing, particularly when substances are involved, like cannabis. And the viewing of pornography may be done on phones and in schools, and youth then may be asked to copy pornography in their own relationships. And females may be particularly at risk. So in several studies specifically focusing on adolescent girls, 30% had reported using pornography, with over a third of those had tried to copy sexual acts seen in pornography. And the girls who viewed pornography in another study were found to be more likely to be sexually active, have peer relation problems, and use substances like tobacco and alcohol. In a separate study of a US probability sample covering a wide age range, close to a quarter of adult women and about 1 in 8 adolescent girls had reported having experienced scary sexual situations, smaller amount of men and boys. And this may link to practices that, concerning practices that have been reported in the media. For example, choking during sex, where a quarter of the women, as was reported in the other study, that this story was linked to that study. Now, from a biological perspective, there may be multiple neurotransmitter systems and systems operating. Here, in conjunction with Errol Kaur and Ruth Feldman, we were investigating pornography-related hypersexuality in men in treatment for problematic pornography use and compulsive sexual behaviors. And we investigated hormones, oxytocin and arginine vasopressin. Oxytocin is a hormone that is linked to, it's a peptide that has been linked to empathy, and arginine vasopressin, very structurally similar to oxytocin, but it's a peptide that's been linked to more aggressive behaviors. So what we found here was that there was a direct path between arginine vasopressin and pornography-related hypersexuality that was positive. There was a direct path between psychiatric symptoms and pornography-related hypersexuality that was the most robust finding, and a positive relationship. And then the relationship between oxytocin seemed to operate through empathy, where oxytocin was positive related to empathy that was inversely related to pornography-related hypersexuality. So all of these systems, I think, warrant consideration and are important from a clinical and research perspective. Now I'm going to shift gears a bit and talk about people with opioid use disorders. There is an opioid epidemic occurring within the United States and elsewhere. Overdoses have increased substantially, both among men and women, and males and females. So some prior data suggested that behavioral addictions might be particularly common in individuals with opioid use disorder. So one study out of Maryland found that 46% of individuals receiving methadone maintenance met criteria for gambling disorder. There may be different reasons. For example, people engaging in gambling for negative reinforcement purposes. I've seen people in treatment for gambling problems who tell me that the chronic pain that they experience when they're gambling, when they're in the flow, the immersive state of gambling, they don't feel the pain that they typically experience, for example. However, little is known about other behavioral addictions with respect to opioid use disorder. So we studied slightly over 1,200 individuals who were seeking treatment for opioid use disorder. We found that 4.5% met criteria for problematic pornography use using the brief pornography screen measure. Pornography use was associated with being male and of minority racial ethnic backgrounds. And it was also associated with substance use behaviors, including tobacco smoking and vaping. It was also strongly associated with psychiatric symptomatology as well as impulsivity. So particularly with respect to psychotic symptoms, but also with respect to alcohol and drug, depression, as well as self-harm. And then with respect to impulsivity, both positive and negative urgency, as well as sensation seeking. So our hypotheses that we had going into the study were largely supported, although we were surprised initially by the relatively low percentage of individuals reporting problematic pornography use. So for example, there's one study of the International Sex Survey that found that about 1 in 6 individuals met criteria for problematic pornography use. However, it may be that there are differences with respect to how different drugs relate to sexual behaviors, where opioids that are more sedating might be less associated with sexual behaviors as compared to stimulants that are often used in chemsex experiences, for example. So another way of thinking about internet use behaviors is with respect to different domains, but sometimes these domains intersect in complex fashion. So for example, with respect to gaming and pornography use, when the Fortnite server crashed, Pornhub reported that the percentage of gamers on the website increased by 10% and searches for Fortnite-related pornography increased by 60%. And then during the pandemic, there were changes in pornography viewing that weren't mentioned. There were increases early in the pandemic. Pornhub had a Help Flatten the Curve campaign where they allowed certain jurisdictions access to Pornhub Premium during the pandemic. And on those days, you can see when the day after they allowed that in Italy, one could see an increase in pornography viewership that then decreased over time several days later. But one can see during the onset of the pandemic in 2020 that there was this steady rise and increase in pornography consumption. There was also, like with the Fortnite-related pornography searches, there were searches for COVID-related pornography that tallied over 9 million searches by March of 2020 at the onset of the pandemic. But what was particularly striking to us was that the timing of the increases of pornography viewing were local jurisdiction time, most substantial between 1 and 3 a.m., raising questions about how this might be interfering with sleep behaviors or what other motivations existed. And this is a graph of the time of day when one saw the increases in pornography viewing. So we put out some guidances about how to prevent problematic internet use during the pandemic. We updated them as more data became available during the pandemic. And we've also put out an e-booklet that addresses a wide range of forms of problematic use of the internet, including those that are related to sexual behaviors. It can be downloaded for free at the website www.internetandme.eu. That's at the bottom of the screen. And we also think that it's important to think about how digital technology usage and pornography on the internet may best be regulated, particularly with respect to developing youth. So in Canada, the Prime Minister and the government has been putting pressure on pornography companies like Pornhub to remove illegal materials. They believe that this could be helpful with respect to reducing the illegal online content and reducing potential child pornography or sexual abuse imagery. And Trudeau has been moving this forward despite the opposition from Facebook, YouTube, Pornhub, and other entities. In February 2022, the bill was discussed, introduced, and it received what is described as massive backlash from several parties, including YouTube, Disney, and TikTok. However, the regulatory plan became law in April of 2023, and it's being debated over time. One of the responses from Pornhub was that it should be exempt and pornographic content should be exempt from regulation because it doesn't have any societal or cultural value. And this opposition from industry is similar to what we have encountered with respect to gaming disorder, when the gaming industry, on the day that it was noted that the WHO was considering gaming disorder for ICD-11, the gaming industry came out with a statement saying that the evidence for its inclusion remains highly contested and inconclusive. We wrote back asking whether this might be a corporate strategy to disregard harm and deflect social responsibility, remembering that it was only about 30 years ago when the executives from the tobacco industry went in front of Congress to testify that they did not believe that tobacco was an addictive product. So where do we need to go? We think that there are a number of gaps that exist in the literature, some of which are being filled over time. And we do believe that there's hope for the future in terms of getting more data in the literature on behavioral addictions, including compulsive sexual behavior disorder. And there are large international efforts like the International Sex Survey, which has collected data from over 80,000 individuals in over 40 countries to ask questions related to these behaviors. Ultimately, I think this Swanton et al. Article has an important statement that multidisciplinary collaboration can facilitate a comprehensive, unified response from all stakeholders, and there are many stakeholders, that balances individual civil liberties with societal responsibilities and institutional duty of care. So I would like to bring the talk to the conclusion, saying that both the DSM-5 and ICD-11 have considered hypersexual behaviors and compulsive sexual behavior disorder with different outcomes, that these sexual behaviors are relatively prevalent but are understudied, and we need more information that we can translate into better public health policy and clinical interventions. So I'd like to thank a large number of individuals and thank you all for your attention.